Fatty liver disease can develop quietly for years before most people know anything is wrong. There may be no pain, no obvious symptoms, and routine liver enzymes can remain unremarkable even while fat and metabolic stress are building inside the liver. But a new 2026 study suggests the body may start leaving clues in the blood more than a decade before the disease is diagnosed. Researchers analyzed blood proteins from more than 50,000 people across cohorts in the United Kingdom and China. They eventually identified just 5 proteins. Together, those 5 proteins predicted future metabolic dysfunction-associated steatotic liver disease, or MASLD, as far as 16 years before clinical diagnosis. And when the protein signature was combined with ordinary clinical information, prediction improved even further. This does not mean there is now a routine blood test that can tell you whether you will develop fatty liver 16 years from today. The model still needs clinical validation before it can be used that way. But it raises a much bigger question. How early does fatty liver disease actually begin? MASLD is the modern name for what many people still know as non-alcoholic fatty liver disease. The condition occurs when excess fat accumulates in the liver in the setting of metabolic dysfunction. That can include obesity, type 2 diabetes, abnormal blood lipids, high blood pressure, insulin resistance, or combinations of these problems. For many people, the disease remains relatively mild. But in others, fat accumulation is followed by inflammation and liver cell injury. That more aggressive form is called metabolic dysfunction-associated steatohepatitis, or MASH. Over time, repeated injury can produce fibrosis. Fibrosis is scar tissue. As scarring progresses, the liver becomes less flexible and less able to perform its enormous list of jobs, from processing nutrients and medications to producing proteins and regulating metabolism. Advanced fibrosis can eventually become cirrhosis, and some people develop liver failure or liver cancer. The problem is that this progression often happens silently. By the time symptoms appear, the biological process may have been developing for years. That is why researchers wanted to know whether blood proteins could detect the direction of travel much earlier. Proteins are useful because they are not just static building materials. Many act as signals. Some reflect inflammation. Some reveal tissue injury. Some are released when particular organs change their metabolism. Others participate directly in the disease process. Instead of waiting for the liver to become visibly fatty on imaging, the researchers asked whether the bloodstream contained a molecular fingerprint that appeared before diagnosis. The study began with large proteomic datasets. Proteomics means measuring many proteins at the same time. Researchers compared people who later developed MASLD with people who did not. From thousands of candidates, 5 proteins repeatedly stood out. Their names were FUOM, ACY1, KRT18, CDHR2, and GGT1. You do not need to memorize them. The important point is that they reflect different aspects of liver and metabolic biology. KRT18, for example, is associated with liver cell structure and injury. GGT1 is involved in glutathione metabolism and is closely connected with oxidative stress and liver function. ACY1 participates in amino acid metabolism. The power did not come from one molecule acting as a magic marker. It came from combining information. Think of predicting a storm. Temperature alone may not tell you enough. Air pressure alone may not tell you enough. Humidity alone may not tell you enough. But when several signals shift together, the forecast becomes much stronger. The researchers built a 5-protein model and tested how well it could separate people who would later develop MASLD from those who would not. For disease occurring within 5 years, the model achieved an area under the curve, or AUC, of about 0.84. An AUC of 0.5 would be essentially random prediction. An AUC of 1 would be perfect discrimination. So 0.84 represents meaningful predictive ability. But the more surprising result appeared when researchers looked much further ahead. At approximately 16.5 years, the 5-protein model still had predictive value, with an AUC around 0.76 in one analysis. In another long-term cohort, performance remained around 0.71 across that extended period. Then the researchers added routine clinical information to the proteins. The model became stronger. At 5 years, the combined approach reached an AUC of about 0.9. Even at roughly 16 years, it remained around 0.82. That means risk information was present long before many participants would ever have been told they had fatty liver disease. And that may change how we think about diagnosis. Today, fatty liver is often discovered accidentally. Someone gets an ultrasound for another reason. A liver enzyme comes back elevated. A scan shows fat. Or a person with obesity or diabetes undergoes targeted assessment. But if molecular changes can be detected 10 or 15 years earlier, the future goal could shift from diagnosing established disease to identifying the trajectory before substantial damage develops. There was another important part of the study. The researchers tracked how these proteins behaved as diagnosis approached. People at higher predicted risk did not simply cross a threshold suddenly 1 year before disease. Their protein patterns followed different trajectories over many years. That suggests MASLD may have a long preclinical phase. The diagnosis date is not necessarily when the disease process starts. It is often when we finally notice it. This distinction matters because the early stages of metabolic liver disease may be the period when intervention has the greatest opportunity to change the future. Imagine two people who both receive a fatty liver diagnosis at age 60. One starts improving weight, diet, physical activity, blood sugar, and blood pressure after diagnosis. The other had been identified as high risk at age 45 and spent the following decade improving those same factors. They may reach age 60 with very different livers. That scenario has not yet been proven by this protein test. But it explains why ultra-early prediction is attractive. The aim is not simply to know the future. It is to create enough time to change it. There is also an important misconception about fatty liver. It is not only a liver problem. MASLD is deeply connected with metabolic health. People with the condition frequently have obesity, insulin resistance, type 2 diabetes, abnormal cholesterol or triglycerides, and cardiovascular risk factors. And cardiovascular disease is a major concern in people with MASLD. The liver is therefore partly acting like a metabolic warning organ. When excess energy repeatedly enters the body and insulin signaling becomes disrupted, fat can begin accumulating in places that were never designed to store large amounts of it. The liver is one of those places. Visceral fat around the abdominal organs often increases at the same time. Muscle may become less responsive to insulin. The pancreas has to work harder. Blood lipids change. Inflammatory signaling rises. The fatty liver is not an isolated accident. It is often one visible part of a larger metabolic network. That is also why simply finding a protein signature is not enough. A predictive test is only valuable if there is something useful to do with the result. Current European clinical guidelines already recommend targeted case finding in people with cardiometabolic risk, particularly those with type 2 diabetes or obesity plus additional metabolic risk factors. Doctors can begin with inexpensive blood-based tools such as FIB-4. FIB-4 uses age, liver enzymes, and platelet count to estimate the likelihood of significant liver fibrosis. Depending on the result, additional testing such as transient elastography can estimate liver stiffness. This is different from the new 5-protein model. FIB-4 is primarily used to assess fibrosis risk in people who may already have liver disease. The new protomic approach is trying to identify people years before MASLD is clinically recognized. That is a much earlier point on the timeline. But there are several reasons not to rush out looking for these 5 proteins. First, the test is not currently an established screening tool. Research performance can fall when a model moves from carefully characterized cohorts into ordinary hospitals. Different populations may have different baseline protein levels. Laboratory platforms vary. Medications, kidney disease, infections, cancer, and other illnesses can alter proteins in the bloodstream. A prediction model must show that it improves real clinical decisions, not simply that it produces an impressive AUC. Second, prediction creates its own risks. If millions of healthy people were told they were at increased risk of developing fatty liver 15 years from now, some would undergo unnecessary scans, tests, or anxiety. Others classified as low risk might become falsely reassured and ignore worsening metabolic health. The model therefore needs to show not only accuracy, but clinical usefulness. Third, the study does not prove that the 5 proteins cause MASLD. Some may participate in the disease process. Others may simply be early indicators that metabolic stress is already present. Lowering one of these proteins would not automatically prevent fatty liver. A biomarker is like smoke from a building. Removing the smoke detector does not put out the fire. The real target remains the underlying biology. Fortunately, much of that biology is modifiable. Current guidelines emphasize physical activity, dietary changes, weight management where appropriate, limiting harmful alcohol exposure, and aggressive treatment of associated metabolic problems. Exercise can reduce liver fat even when dramatic weight loss does not occur. Guidelines generally recommend at least 150 minutes of moderate intensity activity per week, or around 75 minutes of vigorous activity tailored to the person's ability. Resistance training also matters because skeletal muscle is one of the body's major sites for glucose disposal. More active muscle can improve insulin sensitivity and metabolic control. Weight loss can produce particularly meaningful changes in people who have overweight or obesity, although the appropriate target should be individualized. Blood pressure, cholesterol, triglycerides, diabetes, sleep apnea, smoking, and cardiovascular risk also deserve attention. And importantly, normal liver enzymes do not always guarantee that the liver is healthy. People at high metabolic risk may still benefit from structured assessment even when they feel completely normal. The new protein study therefore delivers a message that is both futuristic and surprisingly practical. The futuristic part is the possibility that a small blood panel could eventually identify fatty liver risk more than a decade before diagnosis. The practical part is that we already know many of the major metabolic factors that push the liver toward disease. We do not have to wait 16 years for a protein test to start protecting them. The researchers discovered 5 molecules that seemed to whisper the future long before the liver began shouting. That may be the real significance of this study. Chronic disease often appears sudden only because we begin watching too late. The heart attack happens today, but the arteries changed for decades. Type 2 diabetes is diagnosed today, but insulin resistance may have been developing for years. Fatty liver is discovered on a scan today, but the metabolic environment that produced it may have been forming since middle age. The next generation of medicine may become better at hearing those early whispers. But prediction is only useful if it creates action. The most valuable result of knowing what may happen 16 years from now is having 16 years to change the direction.